Welcome, friends. This is
I'll tell you something.
oh, yeah.
Good afternoon, sir. Raman, sir, we are live. You can go ahead, sir.
Yeah. Thank you, Ortho TV World, for organizing this event. And I would like to thank West Bengal Orthopedic Association, our president, Professor Chinmay, Secretary Parthu Sathi Sarkar, for taking this initiative. And this is the first webinar in India on fracture registry, and we will be discussing on registry benefit, what are the benefits of registry, challenges, and the pilot project which we have started in West Bengal, and about fracture registry in West Bengal. We have very learned faculty, Richard Armstrong and Dr. Keith from UK, Dr. Indrajit Sadar, a senior orthopedic surgeon and from Kolkata, Professor Chinmay and Professor N.K. Das, our president and past president of West Bengal Orthopedic Association, Mr. Bodhidharma Sarkar, who is Vice President of Northgate Services, and Dr. Parthu Sathi Sarkar, Secretary of WBOA. So I would like to start this meeting with welcome address of Professor Chinmay, President of West Bengal Orthopedic Association. Please, sir.
Good afternoon, everybody. Richards and Keith, and also from our state faculties and participants. This interesting webinar, the fracture registry. Nowadays, this type of registry is very much important because it helps the patient, it helps the institutes, it helps the operating surgeons, and also the implant companies. So this is definitely a subject of interest, and we are lucky that we are in first state to start. And about the records, you will have detailed discussion afterwards. But about the records, I think I think there's one doubt about the data sharing. That is, patient's detail. I think patient details should be coded and should be kept with the operating surgeon. Otherwise, they won't forward the complications and adverse incidents, I think. So this should be kept in mind. So let us have the detailed discussion, and we must face the queries of the members. So with this, I conclude my welcome address. Thank you.
Yeah, I would like to invite our first speaker, Dr. Richard Armstrong, who is Director of Northgate Public Services. He will talk on registry benefits and challenges. Richard, please, you can share your screen.
Thank you, Dr. Raymond. My colleagues can just confirm you can see my screen?
Yeah.
Excellent. Great. Well, thank you very much. Ortho World, West Bengal Orthopedic Association, and everybody that's been involved in organising this event. It's an honour to be here to talk to you this afternoon, and very much appreciate the opportunity. So I've been asked to just give an introduction around a sort of worldwide perspective around registries, some of the benefits, some of the challenges that we see as a provider of registries, because I think there's some fantastic opportunities around registries. I think registries can deliver significant benefits to doctors, to patients, and to the wider healthcare system. But they're not without their challenges. They're not easy to establish. They're quite difficult to maintain. And so I thought I'd give a bit of a perspective around what we see around some of those challenges, and also some of the reasons why we think it's worthwhile endeavour to undertake. So I will start with a bit of a what do we actually mean when we talk about a registry. Then I'll talk a bit about why we think registries are important, so why we should be looking to have registries in the first place. Then come on to talk about some of the challenges that we see in setting up registries. And finally then to conclude with a bit about some of the key success factors that are really important, the things that mean registries work or don't. So before I do any of that, just a bit about who I am and who Northgate are. So Northgate are an organisation with specialism in the setting up and running of registries. And we work very closely with doctors, hospitals, We work with the med tech industry because often registries have a medical device aspect to them. We work with government regulators, and in doing that work, we collect, manage, store and analyze data, and give that data back to all of those groups in appropriate format. And I'll give you some examples of that, really around informing safe and effective patient care. So some of the bigger things that we do that people will be familiar with is that we are the technology supplier for the National Joint Registry in the UK, which I think is still the largest orthopaedic registry in the world, now has over 3 million records. And I know Keith is going to talk a bit about that later. But we also provide registries for vascular, spinal, neurosurgery and neuromodulation, to name a few. So whilst we're a UK-based organisation, we actually run some international registries, both in Europe and in partnership with ISHK. We're now working on the Indian Joint Registry. And Northgate's part of the NEC group, so has a global presence. So what is a registry? Quite an important question when we're talking about registries and them being important. So it's pretty simple. So it's a centralized store of data. It's about a specific group of patients who are sharing a common condition or undergoing a common treatment pathway. Really important is the fact that the data is stored in a standardized way, so that all of the institutions that are submitting data to the registry are using the same data standards. And that's what enables us to do comparison through the registry. One of the other really important things for registry is being able to track outcome. So we want to understand what the long-term benefits to a patient is of a particular treatment or a particular pathway, in order that we can do that comparison. And then once we've collected and analysed that data, we then use it to inform doctors and other healthcare professionals about what's working well, what's safe and effective, highlighting things that seem to be problems, and really creating a real world evidence around patient treatment and patient pathways. So where we need a registry is where we're looking to understand what the long-term benefits is of a particular treatment pathway, where we perhaps don't necessarily know which treatments and which pathways are working best for which types of patients. So in order to inform that, we need more data to understand that. I've said we need to collect the data in a standardized way. That's really important. And we need to be collecting that data from as many centers as we possibly can. So collecting a sort of a large quantity of data allows us to better understand what's happening in the population as a whole. And pooling that data across different hospitals without a registry is often very difficult, because different hospitals and different surgeons collect data in different ways to different standards, which means when we're doing comparisons across multi-centres without a registry, it does often lead to some challenges in terms of the comparison that we're able to make. And that's where registry really comes into play. So just drilling into some of those sort of definitions of a registry. So what are the things that we need based on that definition if we want to get started with a registry? Well, first and foremost, we need a secure and centralized way of collecting data, some form of IT system, typically. What we also need, so I'm having some difficulty there, is we need a definition of what the data is. So we want to try and minimize the number of data items that we collect to make it easy for hospitals and surgeons and doctors to put data in. And we need to look at what standards exist for this particular treatment or this particular pathway. So collecting data in a standardized way, getting a consensus about what data is important, and also ensuring the quality of the data that we're collecting. Not all data is good data. We want to ensure that there is some quality in the data that we are collecting. Also, really importantly, we need to be able to understand what it is we're measuring. What are the outcomes that we think are important as we measure this data? And also, really important for the success of the registry is we need effective ways to analyse, compare and feed that data back. So no doctor, no hospital is going to continue to contribute to a registry if they don't get any data out of it. So the feedback systems are really important from early on in terms of getting a registry started. So what are the benefits of the registry once we've established it? Why would we do this in the first place? Well, I've alluded to some of this already. So it gives us that common language in order to evaluate different types of treatments. And then any clinician, any doctor, any institution can then evidence their practice of care against those standards. So it also enables us to understand what types of treatments are working well in what types of patients, and conversely, what types of treatments perhaps are not working so well in which groups of patients, to inform best practice, evidence outcomes, and also to strengthen the research evidence base for particular treatment pathways. And there are benefits to registries for right across the stakeholder group. So clearly there's benefits to patients. It allows us to ensure treatment remains safe and effective, but also to evidence new ways of treating patients to perhaps deliver better outcomes. Clearly it benefits clinicians around evidencing practice. Where we bring in medical devices, in the case of orthopedic registries, there's benefits around being able to monitor the performance of implants. So joint registry data often used to evidence performance of medical implants, understanding what's working well, understanding what's not working well, and supporting device recall if necessary. Some of the key challenges then, in terms of getting a registry started: participation. How do we ensure that we're going to create a registry that is encouraging people to participate and being able to put their data in? I've talked about the need to have volumes of data to be able to give us some confidence around the statistics we produce. This is really important. So the more hospitals, the more doctors we have participating in a registry, the more confidence we can have in the results that we produce. So participation, really important, but often a challenge in the early days of a registry. Sorry, I'm having some funding, I think, is also a challenge. So how do we create funding mechanisms that mean that the registry remains sustainable in the long term? Because a registry does require resources at the centre. Also, a registry requires resources locally. So hospitals and doctors' time to be able to enter data into a registry is often a challenge for people. Everyone buys into the principle of a registry, but finding the time to put the data in can often be difficult. And finally, trust. And I think Keith will talk a bit about this, but it's really important that people trust a registry. Clearly, people are participating in it, putting data in, but they have to have confidence that the data will remain confidential and the data will be used appropriately. So some of the key success factors, and I've talked a bit about this in terms of what makes a registry sustainable and successful in the long term. It has to have some form of impact. So there's no point collecting data if no action is taken on the data. So feedback mechanisms back to surgeons, back to patients, back to researchers that allow the informing clinical practice. A registry needs strong governance. People need to understand who controls the data, who has access to the data, how the data can be used. But also it's important the data can be made available to researchers to support high quality research activity. The registry needs to find some way of being long-term sustainable in terms of having access to funding and resources to ensure that it continues to operate. And in our experience, it is the profession that has to have a sense of ownership for the registry. It has to see it as a good thing, and hence it's very encouraging to be on this call today with WBOA, who clearly buy into the fracture registry. And so some very quick examples of how we produce information. So we often push information back to surgeons, giving them details of their activity, their practice, and giving them some comparison as to how that sits relative to the rest of the registry. So for example, surgeons looking at their revision rates on funnel plots. So confidential feedback to surgeons, it is important and something that we look to deliver early on as possible. Equally, we put information out to patients. That's also something that comes with maturity with a registry, so that surgeons, patients can start to understand what sorts of activities surgeons do, what sorts of volumes. But some of the things that also registries can support in the longer term, particularly things like implant registries, and Keith again will talk a bit to this, is that it can be used to start to give things like benchmark ratings for implants. So I think we all know not implants perform the same, and not all implants have the same level of long-term evidence about them. And registry data can be used to support the provision of these types of ratings in the long term, so that surgeons, procurement, and even patients have an understanding as to what evidence base sits behind implants. And so finally then, so where we fit into this as Northgate, we have quite a bit of experience about registries, about the IT behind them, about the data, and about the security and governance that sit behind registries. But really importantly, we can't run registries by ourselves. It absolutely requires this partnership approach with the profession to make registries successful. So we could put up the best IT system in the world, but if nobody's prepared to put the data in, we simply don't have a registry. And so a final slide from me in terms of the message, in terms of what makes it work. From our perspective, we see we need to provide people with confidence around the data security. So ensuring the data, it remains legal and confidential. We need to make the data entry easy and as simple as possible. We need to ensure the quality of the data that's submitted to the registry, and we need to be able to provide mechanisms for people to access their own data easily and simply. And if I was to finish on one key message, that would be it in terms of what makes a registry work. And I think if we get those four things right, then we will have a very successful registry. And that is the end of my presentation. Thank you very much.
Rajiv, unmute yourself.
Yeah, any question from your side, Samsul?
Not yet, sir.
Yeah. Partho, upload your presentation. So Richard, one question is there. Do we have anything for orthopedic implant like ODEP we have in joint replacement?
Yeah, so ODEP, I mean, Keith, who is also on the call, chairs ODEP, and I think he will talk a little bit about ODEP, but I think ODEP has a lot of relevance for India. It doesn't cover India at the moment, but I think it's something that we need in India. And I think as we develop registries in India, I think we will be seeing more things like ODEP emerging in India that allow a manufacturer of an implant to gain an internationally recognized rating around the performance of their implant based upon data collected in India. So I think it's something that we will see more of in India, and I think it's an important development of having registries.
Yeah. Can I start, Rajiv? Welcome all viewers, dignitaries in the live webinar on fracture registry in India, a step forward by West Bengal Orthopedic Association. I must welcome our President Chinmay Desai, our past President Indra Sardar, our immediate past President Dr. Nilay Kantidas, Richard Armstrong, Head Registry Solution Northgate Public Services, Kate for Chairman ODIP UK, and of course our webinar committee chairman Dr. Rajiv Raman, and for transmitting this in Ortho TV, Dr. Samsul Huda. Today it was my talk about the we have started Indian Fracture Registry. It is an endeavor by West Bengal Orthopedic Association. It is proposed by our seniors and supported by our immediate past president, present president, EC body and general body of West Bengal Orthopedic Association. We the orthopedician, next slide. We the orthopedician regularly encounter in large volume of fracture case, but we have little data about fracture in Indian scenario. I will discuss today about the necessity of the fracture registry in India, analysis of initial data by us, and similar registry that we have found in other countries. A simple data entry of fracture can have various impacts like susceptible population, mode of injury, mode of treatment, various implant we use for treatment, and by doing this registry, we can modify the treatment regime as well as implant design, etc. And also, it has some social impact in terms of patient population and the mode of intervention by government to prevent the incidence of fracture and social awareness. So, why we need this fracture registry? What's the next slide? Hello? Okay. Why we need this fracture registry in India? Any fracture has large social and financial impact in India as that of the rest of the world. But little is known in terms of simple incidence of fracture in India as well as treatment method and outcome. As there is no fracture registry in India, there is scarcity of India-specific data. This scarcity is the main call for high-quality data registry. And if we maintain the high-quality data registry, then understanding the various fracture pattern will be easy, and also that kind of fracture treatment is best, what kind of fracture treatment is best suitable can be understood. This fracture registry will also help to inform the patient safety by monitoring how well fractures are being addressed, and it will also help to track the patient's follow-up. Another important issue is that the registry information can be provided back to surgeons also, hospitals, implant designers, so that they can use this information to modify the treatment as well as design, implant design, and the policy related issues. And registry data will help different hospitals, different organizations, and also government to identify and manage resources so that the best possible care as well as cost effectiveness can be ensured. Next. We have got this similar kind of fracture registry, that is Swedish fracture registry. It was started long before 13 years back and it was implemented in 2011. And they have included first the tibia fracture and the humerus fracture in the trial period, but after that, all the fractures of the long bone, shoulder, pelvis, foot were included. The thing that is very important is that Swedish Orthopedic Trauma Society, a section of Swedish Orthopedic Association, is the professional organization that support these fracture registry. Next. This Swedish fracture registry is so refined that they can analyze different aspects of fracture related information. I have selected only the hip data. It was published in 2018. We all know that these osteoporotic type of fractures are more common in osteoporotic postmenopausal women. And this also shows that the distribution of the trochanteric and subtrochanteric fractures in that age and gender population. And they have analyzed this in minutely according to the monthly distribution of the trochanteric fracture and the subtrochanteric fracture. Next. And they have also analyzed this only heat data by according classification wise, according to the relation to the treatment. They have treated the patient with the short nail, long nail, sliding hip screw, and other methods. And also the 1 year mortality of the males and the females in different age groups, as the mortality increases with this age. And this is the thing that is the evidence-based practice, the need of this time. Actually, this registry information is the evidence which helps safe professional practice. And how this helps? This data helps in patient counseling as well, modification of treatment, then also it can help for medical legal problem also. Next. Now we have started this fracture registry in as a pilot project a couple of months back, but due to this COVID pandemic, this is interrupted for the time being, and we have chosen this time for clearing some doubt about the data security, as well as to motivate all participants for maximum participation and in greater extent in this fracture registry. And with this fracture analysis, I have some disclosure that this analysis of our registry data is based on the basic data with relatively fewer number of patients and participants also. But it includes only 5 hospitals in West Bengal, and record included initial assessment as well as post-op follow-up assessment also. And the type of incidence is shows 63% of the fractures are due to fall, 29% are due to road traffic accident, and 5% due to sports injury, and 3% due to assault injury, and etc. And next, the patient demography. We have analyzed this data grossly that the 52% of the fractures are male patients and 38% are female patients. Also, the 76% are non-smoker and 25% are smoker. And according to the age-wise distribution, it also supports that the active age group, that is the 31 to 70, constitutes 65% of the total fracture, and 11 to 13 30 years constitutes 21% of the fracture, and more than 70% constitutes 13% of total fracture. Next. And initial fracture location, it was the upper limb fracture that constitutes 54%, and the lower limb fracture that constitutes the 54%, the upper limb fracture constitutes the 39%, ankle fracture 5%, pelvis fracture 2%, and spine fracture 1%. And grossly, if we analyze the treatment advice, it is the 78% which is the patient operatively, and the 24% which is the patient conservatively. Next. And 1 month follow-up assessment shows that the fracture status uniting 62%, united 33%, and the adverse incidence 38% associated with the fracture treatment, that is a 38%, infection 33%, poor alignment, weight bearing against advice is 14%. Next. So it is the 1 month follow-up, for the weight bearing advice or not, it is the 76% no weight bearing was advised and 24% weight bearing was advised. So as the participants increases, more and more detailed and extensive analysis can be done for the each data. And with this, we actually treat fracture patients with the highest efficiency. Only thing we have to do is to keep the record. As far as our experience of our senior, this record keeping is a habit. Just like doing this webinar before COVID pandemic, we have a little idea or habit regarding this live webinar to organize or to participate. But now all our seniors as well as junior members are well used to with this. Similarly, if we make the habit of keeping record and participate in registry, it will help both personally as well as socially to have some contribution to our own subject. And another important issue is that it will also help us to keep our own record and analyze our own data. Whenever we participate in registry, our own data will automatically be saved, which will be seen by participant only with their personal login ID, and detailed data analysis of each participant will be sent every month that can also help the participant for further evaluation and analysis of his own data. With this, I conclude my talk. Now, I request Mr. Bodhisattva Sarkar to clear the doubt regarding the data security. Thank you all. Thank you for your patient hearing.
Right. Thank you, Dr. Sarkar. So today, as we present this fracture registry and the question about the data security and all the questions about confidentiality of data, this question has been there since the time we had started National Joint Registry. So everywhere the doctors are very conscious about their patient data, and which is a fair question. And therefore, as we progressed and have learned how to operate registry, we have actually developed various controls and security standards, which actually has built confidence for the doctors in UK, for the doctors in India who are contributing to the Indian Joint Registry. And therefore, we have built in those world-class security standards for the Indian Fracture Registry as well. So these are the, as Richard had showed this slide previously, I won't spend much time, but these are the key areas that has brought the technical standards for this fracture registry for West Bengal Orthopedic Association. And data security and data quality is one of the key standards that we have implemented. So just a quick slides about Northgate, what we have done. Richard had spoken about this, so I will just quickly go to the next one. Is that as I just, one of the point that I just wanted to bring with this slide is that there are two parts in a fracture registry data. One is the patient identifier and one is the rest of the data. Now, patient identifier, we would be happy without having it, but we need that data because we need to connect the initial assessment with the follow-up assessment. Now, to bridge, so patient, the follow-up assessment will happen after 1 month or after 3 months. And to find out the initial data and connect it with the assessment, we need a bridge. This patient data allows us to search the initial record and connect it with the final assessment. What we do in the meantime is that we actually treat the patient records separately with respect to the rest of the data. So it is encrypted in a 256-bit encryption, and this data is only available to the respective surgeon under whom the patient is reporting. So no one else, in fact, none of the office bearers of WBOA also won't have any access. So what this also, another point is that when we actually internally save the data, this patient record is actually then connected with the internal IFR ID. So that is the record number. Now that record number is then connected in the system with respect to the rest of the data. So the rest of the data, for example, we captured the fracture site, type of fracture, treatment proposed, or in the post one, what are the various assessment. So this, although, I mean, what we have to also understand is that we doctors can't remember the IFR record number. So therefore, we actually get this patient data, but treat it very much with care and with lot of security and safety standards. Just to give you a little more data about our emphasis on data security, the Northgate data center is one of the highest has actually got the world's one of the highest security standards. The standards are ISO 27001, 9001, 50001, and other data security standards in terms of the building management system plus the business continuity standard, which is 22,301. These standards actually show you that the data is actually safe as your bank data. So you probably are working with your bank, logging into the net banking. That data, the way that the security standard is implemented, this is also very similar. And for the software security, one of the key things is access control. A doctor whose patient data is going into it can see his patient only. He can't see any other patient data. Similarly, a data entry person can only enter data. He can't see any data which is there. So all these kind of access control, which is very key for implementing the security access, are implemented in our software. So that's what I conclude with respect to the security standards and the data questions with respect to the patient identifiers.
Rajiv,
You're on mute.
unmute.
So now we have one question with our Vice President of North Gates India, Dr. Bodhisita. So how will you so data security of patient, whether do you subscribe the ID number, whether the ID number is different will be different for different state, or for India you will create a UID number for all patients?
So that is one of the challenges that we have faced even while implementing the Indian Joint Registry, that although in UK there is this NHS number, we don't have something similar in India. Something similar can be like the Aadhaar number if we are allowed to use it. But till that time, we get a single unique identifier in India. We have to use this. We have developed an algorithm basically for Indian Joint Registry also, where we use a set of parameters, like it will be the patient name, address, I mean like the PIN number, the phone number, doctor name, all those ones. We will use a set of this parameter to make a search to link the final assessment with the initial, or in the Indian Joint Registry, for example, to link the revision data with the primary. So that's how we are doing it. And we would actually, our work will be even more very helpful if we get a unique identifier going forward.
I think, yes, sir, Sardar sir.
I was thinking about the research projects. If someone wants to do a research on the data, how does he get in, and what is the system like to get that?
So, so this for any research data, I think it will be approved. So data controller of this IFR system is West Bengal Orthopedic Association. Their office executive team will decide actually who they want to give the access to the data for any research project. So that's how we are just the data manager. Data controller has to decide whom they want to give, and we will just follow their advice.
I think it's also important to say that we link the data together, but then we would strip out any identifiable data before it is given to any researcher. So a researcher would have access to anonymized data to undertake research, but they wouldn't have access to any patient identifiable data.
Yes, that settles it.
But at any point, whether the patient identity will not be revealed, whether it is for research or any purpose.
No.
Correct. Yeah, so the patient identifiers remain private to the doctor that submitted the data. And the only reason that we hold them on the system is to support the linkage between the data. And anybody that has access to any of the data, it's always with the patient identifiers stripped out.
Yes, sir.
I have another question, and that is this, that supposing one patient is with one doctor, he gets a unique ID number, and then he goes to another person, another doctor, for the follow-up or whatever. So how will you link it up? Will the ID number remain the same? Will the second doctor get access to the first with the data of the first doctor, or will the second doctor be completely separate? How will you deal with that? Because we're going to do follow-ups.
Yeah, so this is where Bodhi was saying that we use some algorithms. We have some linkage algorithms that look at other identifiable data from the patient, such as Aadhaar number, if we have that, name, date of birth, address, and then we use probabilistic linkage in order to ascertain that this patient is likely to be associated with this another record that we have within the registry. And we surface enough information to the second doctor to be able to confirm the linkage, but without giving them the details of the primary procedure. So we give enough information to be able to confirm that it is the same patient, but not any information that would be private to the previous doctor that's treated that patient. So we're using that probabilistic linkage and the confirmation from the doctor to confirm it is the same patient. However, I think, as Bodhi's also said, that this will remain to be a challenge across the health system until such time as we have a unique national identifier for patients across India. So that the ultimate solution will be to have that in place. But until we do, we will be using other patient identifiable data to be able to do that linkage, but without disclosing confidential information to doctors other than those that are treating the patient themselves.
Like, I think you'll be able to identify it by the name, age, sex, and maybe the phone number.
Yes.
You will be able to do it, but not the doctors, because that would be right, because finally the follow-up data will be coming from a second doctor, maybe a third one also.
Yes.
Any question, Nkedas sir? Chinmay sir? So Richard, there is one question. In trauma, we have so many variables. It's not like arthroplasty. We have so many variables. So how to tackle with those variables?
So, I talked a bit about the need to keep the data relatively simple in the first instance, but I think we recognise that we're on a journey with the collection of trauma data. So I think our collective challenge is to identify the variables that we think are important in the first instance of this journey as we start to collect some data. But what we have seen, even in arthroplasty, is that the data that we choose to collect does change over time as we want to explore variables that we aren't collecting in the first instance. So I think we keep our ask of doctors relatively simple in the first instance as people get familiar with submitting data, because it takes time to submit data. But I think over time, as the system develops, it's very likely that we'll want to add in additional variables to allow us to do additional analysis. But we have to collectively find the right balance between limiting the number of variables that we're asking for in the first instance and exploring all of the potential variables that could be important in trauma surgery. So I think it's a really important point. It's a really valid one. And the other thing that I would say is that when we start to analyze the data collectively, we don't jump to conclusions. It will take some time. There will be reasons why things appear odd in the data that we collect, but only by collecting it will we be able to ask these sorts of questions. So, it will be a journey that we go on, both in terms of the variables that we ask and the way that we analyze the data. And I think we will learn collectively around what we think is the right balance between the number of questions that we ask and people's willingness to submit the data and the way that we analyze the data. And so I don't think we will get it 100% right to start with, but I think we understand the majority of the data items that we think are important for trauma, but I'm sure there'll be others that we'll want to add later on in the journey.
What about uploading photos and videos?
Yes, so certainly something that can be done. We do it a little bit. Keith chairs a committee in the UK called Beyond Compliance, which is trying to look in a bit more detail about arthroplasty surgery and their X-rays and other information are starting to be uploaded where there's a need to analyse things in more detail. So that is also possible to do. The system can support that. And again, we'll be guided by yourselves as the clinical experts in terms of which of those are important and at what point in the journey we think those should be included.
Just to add to Richard, I think we have this feature in the IFR that images below the size of 5 MB can be attached to each record. So that can be uploaded.
Is that photos or videos? Videos is a
Photos only.
Photos only.
As of now.
That's what I was saying. Yeah, that's fair enough.
Rajiv,
So who will do the editing of, yeah, Enketas?
I am leaving because I have to join another webinar regarding pediatric fracture.
Thank you,
All
sir.
right, sir.
One.
Thank you. Thank you for joining.
Thank you, sir.
So once the photographs are edited, uploaded, so whether it will be edited by by your side, Bodhisutta, or it should be edited by the uploading doctors only?
By the doctor. So we will just, I mean, it has to be edited by the doctor. So we will
Doctors.
just preserve.
Yeah, I think we have to edit it in a way which, it hides all the identity.
I think we should have guidelines for that. So before uploading, there should be patient name and everything. Identification number should not be there on X-rays or whatever photographs. So I think we will start our next talk with Dr. N.G. Sadar sir, and he will be talking on fracture registry in West Bengal, a overview. By this time, we will have one more question with Richard. So there is one question from Bangladesh. So what is registry? This is a basic question they have asked. And what is the importance here?
So registry, very simple, really. It's a central collection of data around a common group of patients. But the important thing is the data is collected in a standardized way. So you define your data set, and then you ask multiple centers to submit your data using that data set to a registry. So typically it's an IT computer system bringing in data from different centers, but bringing in the same data. So one of the challenges is deciding, exactly as we were just saying, one of the challenges is deciding what the right data is, what are the questions to ask. And then the second challenge is getting multiple centers to submit the data in the same way. And then, so that will give you your registry, but to make it a successful registry, you need to be able to analyze that data in a meaningful way and present it back to the doctors in a meaningful way. But in its core, the registry is actually quite a simple thing. The challenge is getting people to put the data in and to have trust in it and to how you analyze the data.
Yes, sir. We will start with a talk of fracture registry in West Bengal by our.
Can you see the screen? Can you see the
yes,
screen?
Sir.
Okay.
Yes, sir. You are audible also, and it's, we can see also. Yes,
Okay.
Sir. Please.
We're going. So basically, it's why, and the reason is that we have to understand the patients, the procedures actually to be performed, the complications, outcomes, and then planning the care. And this has also medico-legal significance. Because the thing is that if you find that, say, a majority of surgeons in West Bengal use a particular process to treat a particular fracture, then whatever, if you do the same procedure, you do have the backing because the medical legal thing says that you are doing what, that you're not negligent if you're doing whatever a reasonable orthopedic surgeon would do. So if we find that quite a large number of persons do and say an Austin mode prosthesis. It is in West Bengal, so it has medical legal aspects that you're merely doing what many other people are doing. So understanding the patients, we got to know about the sex, and there are questions really which we all face. Do women get more wrist fractures? Do men have more trochanteric fractures? Are patellar fractures more common in the 20 to 40 age group? Do children get more clavicle fractures? And we all have our own ideas, but we do not know for sure. And we have to depend on the Western data for this. And more details, say in spine, how many stable spinal compression fractures a year? Because this can be treated by most orthopedic surgeons, doesn't require specialized spinal surgeons. But how many would require an operation? How many are neurologically compromised? How many spinal stabilizations? How many require catheterization, et cetera, et cetera. And all of this would be of great importance even to the general orthopedic surgeon, because he will have an idea of whether or not the spinal stabilization is required and to send it to the appropriate surgeon. Fracture neck femur has always been a bugbear for all of us. So how many will we be able to do a close reduction? Would we use 3 corticocancellous screws? Would we use a short DHS? So how many successful osteosynthesis is there? And what are the timings in which we get to do that? How many non-unions, how many AVNs? And this is a question which I think we also need to ask as how long will this data entries go? Because we wouldn't get AVNs and non-unions before at least 9 months to 2 years. So as we were saying about Austin mode, bipolar, cemented, uncemented, and whether really the trend has changed from the Austin mode Thompson type of prosthesis to the bipolar, and whether or not it's a cemented bipolar, the uncemented bipolar, which is more popular. How many of them go into total hip replacements? And out of all this, that will be a boon to industry. And also we can do outcome discussions with patients based on this data, which we are getting. That if we put in, say, a bipolar that's going to last you for 7 to 10 years, if we put in a total hip, it's going to last you more. We know that theoretically. We know that from our textbooks, we know that from our journals, our discussions, our conferences. But even then, an outcome discussion with hard data in West Bengal would be highly appreciated. So conservative fracture clavicle, and that's a huge thing because many things have come about. So do we do conservative or do we do operative in, say, a mid-shaft clavicle fracture? And then the fracture lateral end of clavicle, that's a huge problem because many of us also now still treat it conservatively. But it's the plate screws, which is the sophisticated ones which come about, which have been used. How many are using it? How many are removing these things after 6 months? What are the outcomes like? And of the various operations which are to be done. You use the wires, you use the plates, you use this sort of sophisticated stabilizers, as you see on the picture over here. So all of this helps a lot. And then hand fractures, say the incidence. Which fingers, which side is more observed? Is it the working side, non-working side, conservative? Which splints are useful? Do we do operative in any of them? Does something require operation and to where to go, send them to an appropriate hand surgeon? And the functional outcomes finally of a grip strength, return to work, etc. Because our patients are very, very tolerable to deformities and they go out and work with something which is ridiculously badly united. And they still get along, which is not the purpose of the treatment, of course. But even then, if a patient gets back to work with some sort of deformity, then also the question comes in how much deformity is acceptable. So the sample, if we look at it, we have about 750 orthopedic surgeons in West Bengal. So 10 fractures a month on an average. So that's 7,500 cases a month. Responders, if 75% goes to 5,600 a month. That comes to 67,000 cases a year. And 2 years, it's a 1,35,000 fracture data. And that's how big and how important it is. West Bengal has a population of 10 crores. And that's huge. And if we find this sort of data in 2 years' time, imagine what is going to, what sort of results would be there, what sort of data, what sort of fantastic backing that we'll have for any of the decisions that we make, our hospitals make, and finally our patients make. And if you expand it to whole India, there's 14,000 members of the IOA. and 75,000 responders. So that's with 10 fractures a month, 120 fractures a year. That's 260,000 a year. In 2 years, that's 2,520,000 fractures, more than that. So that's probably the largest fracture registry in the world in 2 years. And that's the sort of thing that we are aiming for. And that's a sort of fantastic fracture registry we can build up, provided we get the go ahead from the Indian Orthopedic Surgeons Association and our surgeons. And I think this will be the biggest change in orthopedic surgery that has happened in the last probably half a century. The Swedish Fracture Registry, which Partha has said, but remember the Swedish Fracture Registry was developed during a 4-year period, 2007 to 2010. And the data collection then started in 2011. But we sort of piggybacked into this and are going ahead with it quite early. But that's because of the experience that is there. And then data entry is fully web-based, including data, cause of injury, et cetera, et cetera. And patients fill out the PROMs. That's a patient-related outcome measures. And that is something which will be difficult for our patients, but which if we nudge them ahead, nudge them along and help them out, maybe that'll be a thing good. And the functional assessment one relating to health status, level of functioning before the fracture 1 year later. And that gives us our best results. And if our patients are satisfied, if they can return to function as much as possible, I think the whole purpose of this registry, whole purpose of orthopedic surgery and treatment will be justified. So from January 2011 to 2015, in 4 years, they had 103,000 fractures. So you can see how much fractures we can get in 2 years' time. This they did it in 4 years. And Sweden is a country which is much, much less than India. So fracture registries have been established and are in development in several countries. Australia and New Zealand, leveled audit published in 2013, Germany pilot project, Ireland has the Irish hip fracture database, there's Lebanon, Slovenia, small countries in their way. Spain, pilot project. United Kingdom, we've heard that today, and United States of America, they own their own bone fragility fracture registry. And talking of bone fragility, this is the osteoporosis studies we can also get about with fractures. So the real correlation with fractures with osteoporosis, and in osteoporosis diagnosis and management mandatory in fractures. And that's another fallout from this registry, this fracture registry that we can build up. So the questions were, why did WBF foresee a need for a registry in India and for themselves? And I think for all the reasons discussed, it's to find out how are we doing, what works here, what works in Bengal, what works in our patients, in our rural areas, in our urban areas, and what is our data. The next question that came about was, what goals are you planning to achieve with the registry? And how will the registry benefit patients, doctors, and hospitals? The principal thing is informed choice to the patient, to the doctors. Which implants to use, what companies maybe, which procedure, hospital confidence on doctors and implants, and the post-operative care. How is the post-operative care going in all our patients? And that will be judged by the functional outcomes and the PROMs and patient-related outcome measures. What is the role of government in this field? That's huge. None as yet, but this has to come about. I'm sure with this corona pandemic, one of the beneficial fallouts would be a greater allotment to the health budget. And if that comes in, then they can step in on this particular point. This crisis functionally or financially may have set us back a bit, but when we bounce back, and we will, these are the areas in which we have to concentrate as an association to get more and more government support. Because the more and more we do get government support, the more and more we are less dependent on industry with their other baggage. So why did you choose to work with Northgate Public Services? I think it's quite their eagerness and their experience. So that made it a good thing for us when we came along. We saw their work in the Indian Fracture Registry. We saw their work in the NHS. And that is something in which we are very, very impressed. So the Indian Fracture Registry will seek to encourage cooperation between national hip fracture registries, improve and coordinate data definition, and maintain their focus on comparability. And this has been successful in hip and knee arthroplasty in the Nordic registers. and also the pilot phase of the fracture fragility network hip fracture audit database. So this showed how a shared minimum common data set supports mutual learning and comparisons between hospitals in different countries. And whether the male osteoporosis or the female osteoporosis, what is the situation here in our country as compared to the others. We all know all the things that the recording that we get is based on Western data. So we should be creating a new osteoporotic data as a fallout of this registry. So now the crucial one, how does a member participate in the registry? So by filling the form. Now Q can do it on paper. That's difficult to do, but that's something which everyone is acquainted in. But more familiar for many who are not yet accustomed to smartphones will tend to use paper. But then that is time consuming. You've got to write it down. And if you don't write it down, you have to look and see who else is writing it down and check whether he's writing the right things. And then how to send paper things. You can send it by post, you can send it by courier, or you can get someone to collect it. Now, post is time consuming. Compliance diminishes by trying to post it. The courier is not possible in many places in the rural parts of Bengal. Costly, and is no surety of reaching the correct place because many courier companies give very false data on whether it is reached. I'm sure the West Bengal Orthopedic Association is very well acquainted with what happened when we tried sending it by courier, our journals and all. Now, one of the key things which we can use is the medical representatives, but again, that is not a very encouraging thing. And sorry. And so the collection, if someone goes around and collecting, that's not practical. It's really not practical. We tried to do it in the West Bengal Arthroplasty Society, and it fizzled out in a very few days. So that leaves us with the internet. The only way which is practical now. Either you can have a desktop or mobile, preferably a mobile. And the question then is who will do the entry and when? And that is the real question for all the doctors because they're very busy doing their clinics, doing their operations, doing their post-op things, doing their rounds, etc., etc. And then finally getting a little time to spend with their families. So if you do my suggestion is this, I mean, something that can be worked upon is this, that if you do write a prescription, do a carbon copy of the prescription. It doesn't require anything, just slide in a carbon sheet, collect all the carbon copies, sit down with a junior or assistant, say once a week, sit down with him for about an hour or so, and you can get 30 or 40 of these fractures, and you can sit down and put it on the mobile. And your junior can do it or assistant can do it because everyone now is more or less acquainted with typing and using the smartphone. So fill in the form on the mobile or desktop every week and make sure that you send. And once it is sent, it's mandatory for those who are receiving it to respond and say that they have received it and to generate the ID code. That is then the ID code that is given, I'm afraid that has to be entered on the carbon copy or the mobile form. The reason why I'm saying this is this. So when the patient comes for follow-up, all you have to do is to search your folder for the name or the ID code. And if it's written on the whole thing, if the name is written on the carbon copy, you have a backup, you won't forget it. So entry again at 6 weeks and 12 weeks, rare cases you do later. And then as I was raising these questions, this goes to another doctor. So that has to be matched by Northgate, by name, age, and address. And information to the first doctor that this patient is being followed up by someone else. You need not say who is the second doctor, but say that he is being followed up by another doctor. The follow-ups by the second doctor, the same ID has to be given to the second doctor. So he can, the question is to be accessed by both doctors or second one only. My feeling is the one who is in actual management of the patient should be the second one. And that thing something which I think as we were discussing, Northgate has to follow. So this is what you see, Dr. Arnab Kundu works with me. Well, that's his mobile phone, and that's a prescription which is entering into it. So that's the way we are thinking of doing it. Statistical collection, one person from WBOA is approved by the WBOA for IDs. And that is the thing, the research projects. And that is what Bodhi was saying, and that is what Keith was also saying. So that has to be an identifiable person from the WBOA. And he only gets the IDs. He doesn't get any other detail. So the data is analyzed and presented every 3 months or 6 months. And after 6 months, it's to be presented at IOA for acceptance and then to be taken over by the IOA, because then we would have done the pilot project, made sure of the advantages, the disadvantages, the bottlenecks, and the plus points, and give the IOA a ready-made registry sort of thing to look down. So we got to start of the lockdown is withdrawn, and we are all praying and hoping and wishing it'll come, the lockdown would come down. But we understand that that is a decision which has to be taken by those who are doing it, because that has other connotations, other things about this pandemic spread and all. So this is it. This is what I had to say about the West Bengal registry. Thank you.
Rajiv,
Hello. Yeah, please unshare your screen, sir.
Yeah, I'm not sharing.
So, as usual, excellent presentation by Indri Sadar sir. I think he has given some valid suggestions also, which can be taken out, because this is important. Either we can have a desktop-based or mobile-based. And nowadays, all of us, all of the orthopedics are using a smartphone. I think mobile-based app will be a good solution. And by that, we can put data entry, we can increase the collection of data. There is one question with Sadar sir. So,
Yes.
how to implement this? This is very difficult question, task, because we have a government setup, we have private setup. So how to implement this?
I think this is individual, really, because the advantage of the government sector is that they have people working with them. Say the medical colleges will have their PGTs and all, or the junior surgeons. The ones working in the rural areas in the government hospitals are really hamstrung. But then they also generate a lot of these patients, medical officers, etc., who are attached with them. So this is something that the initiative has to be taken by the surgeon concerned. It is not difficult. It is not difficult, and maybe if you can attract them to a Saturday afternoon of, say, tea or biscuits and chops or cutlets or whatever, I think they'll all sit down and you have a good time and spend an hour just doing this. This is something which has to be done, because if we are sure that we have to do it, we all know the ways and means of how to do it.
And regarding, there is another, any question? There is another question, as in hip registry and knee registry, there were complications were also reported. So there was a scenario for getting a questionnaire from the NHS in UK for outliers, whether that will happen with trauma registry also, because if number of complication increases, a particular surgeon will think that the complications are high. So whether you will put complications there also. Question to Dr. Sardar and Richard. First Sardar sir, then Richard.
I think the complications have to be put in. I think what Partho has given in his talk, as you saw, there were many areas, and there were 74% of operative procedures, but there was a 33% of not good reductions. So this is something which we all have to look to as an association. It has to be, of course, very secretive and private and all that, but it is possible that a small little, sometimes if someone looking at it and can identify, it's difficult. It's difficult, but to say that, but some sort of methodology has to go back to the surgeon. That if he sees by himself that all his operations are not really going in, because adult education is self-education. That's what Dr. Ranawat said, that's what's said everywhere. And if someone doesn't self-educate himself, his results are going to be bad. And if his results are bad, as you know, in this very, very competitive field, patients are not going to go to it.
Yes, Richard, your view on this?
Yeah, so I think that comes with time in terms of outlier analysis. So the National Joint Registry in the UK, it took 5 or 6 years before they started getting into routine analysis of outlying data. I think, as Dr. Sadar has said, that the feedback, confidential feedback to the individual clinician comes first. Developing robust statistical analysis of the data becomes important. Collecting enough data to give us robust statistical analysis is important. But it is important that the registry does look at practice and has processes in place around escalation where issues seem to be appearing in terms of adverse performance. So it is an important aspect and part of a registry, but it comes over time and with maturity, and you don't go there in the first instance.
That's a great thing. There's time for us to mature.
Yes.
Yeah. There is another question for Indrajit Sardar, sir. So right now, how are you maintaining your data?
As you saw, most of this we were maintaining our data by looking at it really, not using the carbon copies as such. This is something which I was thinking of because many surgeons use that. And I thought this would be a good idea for this. My data maintenance is basically on that. The patients who are operated upon, they are in their hospital, we get their details. And that we have a lookout for what are the fractures, what are these areas and all. I had thought of participating in this WBA registry, but then the IOCON took the wind out of my sails. It took my all my energy away. But now that once this thing is over, I can assure Parthu that we'll be one of the biggest suppliers of data as we go along.
Another question is, what should be role of government, sir, in this while creating awareness for registry and implementation of registry?
My feeling is that you cannot do without government. This has to be. Without government, this thing cannot really go along. So the government has to be convinced. And the government has to be convinced that it helps them in their own way if such a data is there. But this data will not be accessed by them. And that is the fundamental thing that has been told to them. Because governments, you know, they will want everything, they will want their fingers in every pie. So that is something which has to be clearly mentioned to them, that they will help us, this will help them, but they will not have any access to this data as such, except the ones which are sent by the WBA, by their certified, approved person, researcher, who will get the data, and that is shareable, and that can go to the government, of course. And that is something you tell the government, that we'll be giving you data time to time, but you don't get into this. And the finance part of it, yes, that is something which the government has to give. And that's what I was saying. Once this health budget increases, it will definitely after this. It's a sacrilege if they don't improve the health budget after this. But once that is there, there'll be, I think, reasonable money enough to get going. That's, of course, that Northgate doesn't charge us too much.
There is another question, sir. For India, the expenditure on health is almost negligible out of proportion of the whole GDP. So whether if the government increases it, that will help in creating awareness and registry protocol and maintaining registry protocol.
Yes, of course. If they do increase it, that's the area where we must push all the associations for the registry. It's not just the orthopedic ones, but the surgical ones mainly, and all of the surgical stuff. And the orthopedic ones especially, we have to push. Once they allot that much of money, we should jump into the fray and try and get something from that.
I think we will have one more question, Keith. By that time, you can upload you can share your screen. Yeah. So there is a question from Nepal, sir. So what we are planning to achieve from this registry? So why we should go ahead and why, how it will help us? I think we have discussed. If you can summarize.
We get, I think we've discussed this hugely, but anyway, just to summarize, we get data, our own data in our circumstances, in our patients. We get a standardized protocol which is followed by most surgeons, which will help us in our way, in our medico-legal reasons also. The third is that in the outcomes, one can assess individually as to what is working for him in his situation. That won't be done by any other means. The registry will be hard-cold data in which one can assess oneself And one has to really assess oneself periodically as surgeons as to what they are and what they are doing. And are they improving, or what is to be done to improve themselves? So all of these are there, plus the data allows you for comparisons with others and collaboration with the other registries. Like if you find that your hip replacement data is similar to the Swedish ones or the UK ones, well, that's a huge confidence boost to us. So because then we know that there we are in a global party, and we are in our own selves and with the confidence and the ability demonstrated by the data as to be on a par with anybody else in the world. That works huge. That's something which Nepal should be aiming at also.
Thank you, sir. I think, Keith, if you can share your screen right now.
Can you see it?
Yeah.
I'm sharing
Okay.
at the moment.
Yeah.
Okay, can you see me?
Yeah, we can't see your presentation.
Oh dear.
Open your PPT, then share here.
Okay,
So first,
so I go to share screen.
yeah. And now you click on the PowerPoint. Yes.
We there?
That's
Yes,
it.
it's here.
Presentation mode. That's
Okay.
it. Perfect.
Yes.
Thank you. And greetings to you all. And we all feel for everybody in India who's unwell, just like in our country. We've got a big problem at the moment. It's an honor to be invited to speak to you about our experiences with the National Joint Registry and ODEP and Beyond Compliance. My declaration of interests. Okay, so I think Richard's covered this, but I speak just as a simple surgeon. The basic concept of a registry: you get a patient, and you take their the demographics and put the device barcode. You have a register, and then you have that's a lot of data. Then you have attribute filters, and that turns it into what I think is a registry, something which is really useful. But then you need, as Richard was saying, clinical input, and that with the registry gives you patient safety. And I stating the obvious, I mean, a registry, it's of absolutely no use unless it's useful to everybody. We've found the National Joint Registry in our country fantastically useful, because before then we were just guessing. We wrote papers, but really it's this big data that really you can use to make a decent, make some decent evidence and decent decisions. And I think, I'm going to point out pretty well the obvious, but yeah, I think we all agree that patients want good surgeons and good implants, and surgeons want to use good implants. Surgeons like to know they're doing okay. You've been talking about surgeon performance just now. And surgeons like their patients to know that they're doing a good job. Hospitals want to know they're employing good surgeons. Hospitals want to know they're using good implants. And good hospitals want the public to know that they are having the highest standards. This is all very obvious, but sometimes the politicians need to be told this. And of course, manufacturers, they need to know that their implants are okay. And they will advertise this fact. And of course, they will use registry data to get the data. And of course, they'll have to pay for it. So, but what have we learned? Well, everyone using your registry data must believe in it and have every confidence that it's accurate. And you were talking about confidentiality and all this, and that is desperately important. And I should just say that working with Northgate over these last N years, the data in the NGR is very carefully looked after. If there are mistakes in the data, they've got to be corrected quickly, and you've got to admit to them. And everybody who's uploading data has got to be compliant, and it must be complete. You see, if I mean, we've found in our country that there are people who want to knock it, and if it's erroneous in any way, people will, or if they're worried about the confidentiality and so on, people will get on your back, and then everybody will lose confidence, and then the game's lost. So just to remind ourselves, completeness, that's when a registry like the NJR in the UK means that for completeness, you've got to have more than 90% of the hospitals in the country contributing to the data. So a patient can't escape from one hospital to another and you lose the data because they have a revision somewhere else. The surgeons have got to be compliant. They've got to upload their data. And this word linkability, you are using the word bridging between revisions and primary procedures, absolutely essential, because certainly for joint replacement, hips, knees, shoulders, elbows, ankles, revision is the key metric. I'm also involved in the spine and other registries, but for what we're talking about today, revision is the key metric. And of course, you know, we do use PROMs as well, but the revision is the most important thing. Now, I think, you know, the number one message to make a registry successful is that you must make sure all the stakeholders gain from the registry. I think we were a bit slow on the uptake about feedback. I don't think we gave enough feedback quickly enough to people who are actually taking the trouble to input data. Okay, well, just a little bit about the history. I was right at the very beginning wanting a registry. And this is what Sir John Charlie said in 1972. Serious consideration should be given to establishing a central register to keep a finger on the pulse of total implant surgery on a nationwide basis. Unfortunately, our government wouldn't listen. That was until we had a problem. Oh, I love showing this slide. That's John Charlie on the left, the shorter guy. And the other one is Ken McKee, for whom I worked. And they've both been skiing and they both got bruises on their hip, which is just, anyhow, I digress. So our registry started principally because of a disaster. On the left, you see the Charlie, a jolly good implant, did fantastically well. And on the right, something looking very similar, the 3M capital hip, which was a disaster. We didn't even know who'd got them. We didn't know how many were bad, but it got into the newspapers. And that's what triggered our registry. And the first thing was because we couldn't contact patients. So one of the first things about our registry was actually so we could make contact with patients should something need to be, you know, if there's a field safety alert or you're going to withdraw a registry. And that's what was so the first thing. So obviously what we're trying to do is to improve results for patients. And to do that, we want to monitor prostheses. We want to support surgeons and hospitals, identify the good. That's very important. Everybody thinks about registry focusing on the bad. We support research, but principally we want to prevent disasters. Now, as Richard said, we've now got over 3 million uploads in the NJR. Hips, knees, ankles, shoulders, elbows. So what will we get out of it? The information we need. Well, I think we all like to look at trends. That's important. We look at good practice. We look at dangers. As I say, feedback is so important. Getting data and feeding it back. The data for benchmarking, I'm going to concentrate a little bit more on that in a few moments. PROMS data, and of course, the data for research. We publish every year the annual report. That's the picture of last year's, and you can go online and get it, it's an awful lot of data in it. It's well worth a look. I mentioned trends, just a few examples. Here's the trend with fixation in primary hip replacement. You can see the purple dots starting off on the left-hand side. That was cemented hip replacement. And then the blue is uncemented. You can see how that's overtaken cemented. And then you can see the orange coming up underneath. That's the hybrids, the cemented stem and uncemented sockets. And you can see the green there, that's resurfacing, and you can see how that sort of pretty well crashed. The bearing surface, interesting. The top line there is metal on plastic, and the blue you can see coming up very fast is ceramic on plastic. You can see the orange metal on metal crashing, and you can see others along the bottom. Yeah, we suffered badly with metal on metal, and there's a graph on the left about showing cemented primary hip replacements, the standard ones, and then you can see what happened with metal on metal, that orange level line above, and then on the right hand side you can see the same sort of thing, but this is for the uncemented hips. It's quite interesting to look at, well, it's important to look at how hip replacement fares in different age groups, in men and women. And you can see on the left-hand side how the revision rate, that purple line for men under 55 is of course much higher than for the older people, and then it's higher than for women. I think we all find this data is very useful. Here's knee replacement, primary total cemented knee replacement by the different constraint and bearing. This is a picture. This graph is of patellofemoral. That's the orange line, and then we've got the uncemented unicondylar knee replacement at the blue line, and then underneath the cemented. And you can see their revision rates, of course, are very much higher than the revision rates for total knee replacement. There were just a few examples. But as Richard was saying, there is absolutely no point in collecting data unless it's fed back. And we have supplier feedback. That's to manufacturers. They have a portal in NGR, so they can access it. They can access NGR and they can look at their data. They can't look at anybody else's, and they can do this 24/7. And it's very, very popular. And I think we're probably the only registry in the world that offers that facility, which makes us extremely popular with manufacturers. Hospital feedback, very important, and of course, clinician feedback. I wouldn't be showing you the next graph, which is my little triangle, of course, unless I was doing okay. The red dots are surgeons who are outside the limits, and principally they're outside the limits for metal on metal. So that's a little bit about feedback. And then, of course, you've already mentioned research, and the NGR has been fantastic for research. About every year, I should think we get about last year we had 270 requests for data. And anybody wanting NGR data can apply. We have 2 research fellows, and it's based at Bristol University. And we have what we call internal and external research, and it's very busy. Here's just a few examples. 60 papers in the last 7 years, that's in peer-reviewed journals. And there's been a lot of different types of research, epidemiological, implant-related, and so on. Just a few examples. We looked at death rates in total joint replacement. We looked at mortality, knee replacements. We looked at aspirin, low-molecular heparin. I mean, all these papers are available. Yeah, this is, I think, a very important paper. We looked at the predicted 5-year revision rates for different size resurfacing in women and looking at their age. And you can see that with a small head, the revision rate's pretty high. Goes down a little bit when the heads get bigger, but certainly. And then you come to men. If you look at the bottom on the right, 1.9% with a 28 millimeter hip, but 28 millimeter, which is the standard hip, but then 2.6 with a 54. So what this tells us that women who have small heads do badly with surface replacement, and men with large size heads do quite a bit better. And over 55, it's probably not a good idea to have surface replacement. We when the metal on metal problems emerged, one of the suggestions was that they were going to cause cancer. And so we were able to put our registry, link it up with the cancer registry, and show that metal on metal didn't actually cause cancer. And that was a pretty important thing to do. And of course, it was reported in the Lancet. And then Steve Graves's unit in Australia suggested that cardiac failure was more common in metal on metal hip replacements. And again, we were able to put our registry in connection with the cardiac failure registry in the UK and show that there isn't a linkage. Pretty important. Took a lot of work, but well worth it. So what have we learned? Well, I think you touched on this earlier on. I think we learned that making the National Joint Registry mandatory certainly helped a lot. It improved the compliance. This bridging linkability is absolutely essential. We've learned a lot from other registries. And one of the things we did decide in 2015, we needed to be a bit more granular. And we may have missed some revisions. And we've learned of the dangers of big data and this camouflage, this thing that you could have 100,000 of a very good knee replacement, but within that group, a small group of perhaps a high flexion device or something like that, which could be, and those having poor results, and they could be camouflaged by the very good results of the rest of the cohort. As I say, minor modifications by manufacturers and slipped in to a large cohort is where the problems occurred, and what we've adjusted to that. Okay, I've got a blank slide here because I thought, well, this is sort of halfway through my talk, and so give your mind a little break for a moment, and then go on to what I'm actually particularly interested in. I hope everybody's doing okay. And that's benchmarking. And ODEP, I've been privileged to be chairman of the Orthopedic Data Evaluation Panel since it kicked off. And of course, we rely very heavily on registry data. It's a very good use of registry data as far as we're concerned. We also started after the disaster of the Capitol Hip in 2003. And what we do is we ensure that manufacturers, I think this is what the most important thing about ODEP, we ensure that manufacturers have to collect and look at their data. And we use data from the National Joint Registry and all other and many other registries and sources. I think we're the first and essentially the only system to demand an ongoing evaluation of a medical device. So we demand that they have to rewrite the paper every 2 or 3 years. We've had about 1,900 submissions since we started. We do about 200 a year, 250. And we reject quite a few. So manufacturers submit their data to support the continuing use of their product, and we award benchmarks on the basis of their submission. The number represents the years of use, and the letter the strength of the evidence, and they can't stop moving. They've got to keep going. The data they use comes from registries, RCTs, peer-reviewed publications, podium presentations, and in-house data. We're very happy to have data, all data that they can get hold of. And they load the data against a grid. Now, I hope that you've received, all of you, the submission copies of the electronic copies of the submission forms. And if you haven't got them, we can certainly send them. This is the grid. You can see there at the top, the number of centers. We demand at least 3 centers. The number of surgeons, and then you're going down the left-hand side, the number in the cohort. And you can see that for the 3, 5, 7, 10, 13A star rating, those are the figures. The revision rate to get a benchmark at 13A star for hips, you've got to have a revision rate less than 6.5%. We have A ratings where it's similar, but the confidence intervals are larger. And B ratings are for boutique implants where they're not very commonly used, something like a CDH prosthesis. So at 6.5% for a 13A star rating for a hip, and for 3% for a 3A rating. Knees, which is the next grid, you'll see that we accept 3.5 maximum revision rate at 3 years, but 6.4 has dropped to 6 at 13A because knees have a higher rate of revision earlier on, but a lower rate of revision later. And all this data is, all these revision rates are based on worldwide data from registries. Now, the next slide shows the criteria for unicondylar knee replacements. And you can see there, based on worldwide data, the revision rate we're prepared to accept for 13A star is 17.5%. That actually is going to come down because what we do is routinely, we look at the revision rates of various implants in the worldwide data. And recently, the revision rates for unicondylars, particularly for 2 particular unicondylars, has dropped. And that figure will be changed in the next year or so. So who uses ODEP data? Well, surgeons certainly do. Hospitals do. Hospitals won't buy implants in the UK unless it's got an ODEP rating, and patients. And the ODEP ratings seem to be used pretty worldwide. And I see that, people in India get on and take a look at what we're up to. Well, that was ODEP, and ODEP was going along reasonably well. But we were hit in the UK by metal on metal, surface replacement and stem metal on metal. And of course, the worst ones were the ASR. And that's the revision rate, that horrible brown line compared with the revision rates for regular hip replacements. And we didn't exactly miss these, but we probably got onto it a bit too late. And we looked at we looked at ourselves and think, well, really, where we're getting it wrong is we are not monitoring implants quickly enough from the moment they get on the market when they've just got their CE mark. The CE mark is the conformity European, which is used in Europe. And so we developed this system called Beyond Compliance, which is a national joint registry based system, which I'd just like you to briefly talk about for a few moments. It's a service evaluation. And as I say, it's about 9 years ago, out of frustration that we were still having bad implants in the UK, that we went about this and started Beyond Compliance. So it's Beyond Compliance in vigilance, in diligence, and it has to be voluntary and it's independent. So when a manufacturer has a new implant, they come to us and we undertake a risk assessment. They present, we look at it and we give them a risk assessment. And then we arrange for data collection and reviews and user group meetings. Yeah, this is an example. When we're doing the risk assessment, we often compare the implant they're presenting to us with a benchmarked implant that we've got with a 10-year benchmark. And the ASR had got a different metal. It got a thinner shell. This is compared with the BHR, less head covered, beveled edge, smaller clearance. A lot of changes, and that would have made it a risk level of 4, a high risk level, and we'd have informed the manufacturer of that. Now, when it comes to monitoring, we put together a repository for each implant that enters Beyond Compliance. And you were mentioning earlier on about what we can put into that repository. Richard mentioned that we could put in X-rays, we can put in some movies, follow-up notes, of course, the revision data, HES data, that's hospital episode statistics. We can look in scores, we can put data from other registries. We have an explant analysis committee, and then we can export that data to the manufacturer and to the surgeons who are using that particular device. And we've been doing that for the last 9 years or so. And we've got about 50 implants going through the system. So we do a risk assessment, we collect the data, and then we review it. We review it actually monthly, but we review it with the manufacturer either 6 monthly or each year, depending on how things are going. And we also run user group meetings. These are where we get as many of the users involved in the implant, ourselves and the manufacturer together, and discuss how it's getting on. And that's really important. And then we do drill down. So we think there's something not going terribly well. We contact the surgeons, we write to them, and we drill right down into something, any aspect of the performance of the implant that we're concerned about. This is one particular implant we've been dealing with. If it's a knee replacement, if they use a resurface, if they resurface the patella at the index operation, it's doing fine. If they don't, it's doing badly. And we pass that information back to the manufacturer, and they are now advising surgeons to resurface the patella. Now, you've been mentioning apps. We think this is the way forward. And I think that everything that's going on in this country at the moment with COVID and everything else, I think that's going to push communications along quite fast. And we've developed an app for Beyond Compliance, and patients can get into it, and we can communicate with them. And that's in development, but it's going to be around pretty quickly. So getting towards the end, the Indian Joint Registry, we have got the Italian registry, the German registry, and they're sharing our database, which is run by Northgate, and they're running the platform for your registry. And so to my mind, before long, it should be possible for your registries to supply your manufacturers with your data and to increase the safety of your patients and to promote their good implants, because that's what's happened in this country. And we would be honored to work with you if you felt it would be beneficial. I'd just like to reflect on, my sort of personal experience with the NGR. I was involved in it right at the very beginning. In fact, I was one of the people who championed the idea. And in 2003, there was a lot of surgeons who were hostile towards it. They're worried about confidentiality. They couldn't see the advantages. The compliance was low. They thought the data collection was far too big, and they were worried about being an outlier. And they were suspicious. It's all changed. Very few are hostile. They use their data, and they're proud of their data in their appraisals. They want more and more information. We have well over 95% compliance with surgeons. They're telling me that the MDS, the minimum data set, is not big enough. And they all agree. We want surgeons to be safe. And for most part, in our country, they're very proud of their registry. And so, in conclusion, I think you're on a great path, and you have the opportunity to prevent a disaster. We had to wait for disasters to happen before we got our registry. I'm very fortunate to work with a great team, and I'm just a spokesman. Certainly working with Northgate has been a privilege. So I'd like to acknowledge all the patients who've given their data for putting this presentation together, and my colleagues. I thank you for your attention. And if you'd like to contact me, please do so. And I do hope the cricket starts again soon. So many thanks.
Yeah.
Thanks, it's excellent talk. And I think Sada sir, you are having one question.
Yeah, I had one question. How did you make it mandatory, the joint registry?
Well, I think the compliance wasn't as good as it ought to be. We were spending a lot of money, and it was very frustrating. There was, and and so there was a big push to say, look, this is silly. I mean, you know, in our country, we had lots of people saying, oh, well, you shouldn't do this. You should, you know what English people are like, British people are like. They're pretty independent. They don't like being told what to do. And but I say we weren't getting the data we wanted, but also we had metal on metal, and there were 2 hospitals, particularly that didn't contribute to the registry, and they were big users of metal on metal, and we were worried about metal on metal. It didn't look right, but we couldn't call it because the confidence intervals were too big. Making a call on an implant is a big step because it's essentially going to have a field safety notice. The MHRA, that's our regulator, is going to be involved. Now, if those 2 hospitals had actually contributed, we would have called it. We'd have had statistical confidence a year before we did. So that was another thing. So we had an argument. So our chairman went to the government and said, look, this is silly. And they all agreed. And they said, right, this is going to be it. And it's mandatory. But it was on the back of another disaster. And it's the smart thing is to try and get these things in place without having to rely on disasters.
So you would recommend that we go to the government and to make it mandatory for all hospitals?
Well, if all the surgeons are going to agree to upload their data without any argument, then you probably don't. But if you need pressure, and also if they say the hospitals are saying we haven't got any staff to help with the filling the forms up and all that sort of stuff, then you might have to. I mean, but the situation now has completely changed. It's in the UK. It is not cool not to put your data in. I mean, for a surgeon not to be uploading their data, it'd be like smoking in church or something. I mean, it'd be terrible. It just doesn't bear belief any longer. But years ago, it would have. So once you get past that threshold where it's just not the right, you've got to do it. If you're a professional, you've got to submit your data, and that's it. So once you get to that, you don't have to worry about mandate. And now I think if we stopped it being mandatory, Richard, I think everybody would carry on doing it. But certainly the impetus was helpful. And I think it was more helpful, probably not less on the surgeons, but actually on hospitals to provide staff and computers and all the bits and pieces that you need to actually do the job, because the pressure was on them. And if a hospital isn't uploading, isn't contributing, then somebody was going to visit them and say, look, this is not acceptable.
That's a great pointer.
It was hard work. I think the consent form, we spent so long trying to work it out and get it right. But patients have to sign consent, which is good. And as I say, the data is very safe where it's I can't get hold of it. So
There's one more question.
Please.
Regarding access to data, it's accessible to doctor, accessible to hospital, but how it is accessible to patient, access to data for patients?
Well, their own data. I think Richard would have to answer that, but I don't think it is accessible. I don't think a patient.
No, so we provide a service on the registry such that any patient is able to request a copy of their own data, and we do that quite a lot actually. So obviously we go through a process of authenticating that the patient really is who they say they are, firstly, but once we've validated that, then we will give them details of their record. And the sorts of questions that we get, quite often when things go into the newspapers about implants, we then get phone calls from patients saying, does that affect me? Have I had one of those implants or not? Because often the patients don't know. So we will then give the details to the patients of the implants that they've had. So as part of the registry, we provide that sort of service directly to the patients.
Yeah, sorry, I did know the answer to that, because I remember when we had all the metal on metal, a lot of stuff was going across my desk.
I think we are having message from Ortho TV to conclude meeting. We are overshooting time. So final concluding remark by Indrajit Sadar sir and a vote of thanks. So unmute yourself, please.
I think we've had a fascinating discussion. We learned a lot, and bottom line is this, that registry has to be on. The second question is how to make it mandatory, and we try and do it whatever way we like by discussions and later on. But thank you, everybody, especially our overseas colleagues for wonderful lectures and contributions from Partho, very good things that you did in that very short while. And Rajiv, congratulations for a great conducting. And I think congratulations to Dr. Huda for being so patient.
Thank you, sir.
Thank you so much.
Thank you so
Thank
much.
you.
Yeah.
Thank you very
Thank
much.
you very much.
Yeah.
Thank
Stay
you,
safe,
sir.
stay well. Yeah.
Yeah, with this, I'm stopping the live streaming, sir.
Yeah.
Okay.